Hello again. This is a small little series we're doing at a Highland Hospital regarding our blocks and procedures that are all ultrasound guided. My name is Arun Nagdev, and I have a special guest today. This is one of our current ultrasound fellows, Rob Farrow.
Hi, Arun. Thanks for having me.
Great. So we're going to start off with a simple, short little story. This is a patient that came into our ED with an abdominal wall abscess. She was sweet young lady, but had a long history of opioid dependence, and was not going to be able to tolerate even us touching this abscess. You can see right here, she was not even going to let us touch this, and procedural sedation would have been a nightmare for her, because I think a large dose of ketamine and a lot of propofol would have been necessary to kind of get her comfortable. So at this point, we decided that for this abdominal abscess, a TAP block would be a really good tool for us to drain this abscess and get her out. She's actually in our fast track region of our ER, and we had her on a monitor. I was talking about this case and how successful it was, and I'll show you the technique. And then Rob actually texted me the next day when he was working at an outside facility with his case.
Yes, so this was an interesting case for the use of TAP block. It was actually a pediatric patient, about 15 years old. Had an exam that was concerning for appendicitis. There was an inconclusive ultrasound done, but given the physical exam findings and concern for appendicitis, the mother was very concerned and actually opted for CT imaging. CT imaging was negative for appendicitis and actually was more diagnostic for mesenteric adenitis. So a TAP block was actually appropriate for pain control still.
So a nice idea, and again, I didn't even think about this, but a really nice idea for somebody that needs pain control for something that we classically just give ibuprofen for and tell them to suck it up. So just to kind of go over the anatomy for the TAP block, and this is the lateral TAP. Really, it's a space between your inferior part of your costal margin and the superior part of your iliac crest. You can see it kind of gives you, it can get all the way down here. We've done them before for gallbladder issues as well, which will get a little bit higher. But this is kind of the basic idea, and it's surprising to think that we only have this little bit of space in between that. And again, the probe marker with the probe with the probe marker in this direction, and you can see the ultrasound system is contralateral, and this is going to be an in-plane needle approach to get anesthetic above the transverse abdominis plane, or above the transverse abdominis muscle in the transverse abdominis plane. I'll show you kind of what you see whenever you do this. It's kind of a very simple visualization. This is your external oblique, internal oblique, and your transverse abdominis muscle. The goal is to separate this fascial plane with anesthetic. And this is commonly very easy to visualize. This is a schematic I drew, and really the goal is to bring the needle down with visualization and drop anesthetic again above the transverse abdominis muscle. Fluid will track in this plane and give you anesthesia all the way around. And what's nice about this, it traverses both cephalad and caudad and will give you a nice block plane. I remember Rob was just starting the fellowship. He'd never done one, and I walked him over, and it was not too difficult of a block, is it?
No, I think this is actually a pretty safe block. I think that given that we're doing this similar kind of viewing for assessing for ascites or even for paracentesis, I think it's a view that a lot of physicians are going to be very comfortable with. And once you identify the musculature planes, I think it's an easy block to adopt. So
again, the needle comes in, and again, the idea being to drop fluid above the transverse abdominis muscle and to open that plane up. I will say that sometimes the needle visualization is not great on this because you're coming at a steep angle. I would recommend starting and following the needle down as you go into through the external and the internal oblique muscles. You can see this is about 30-minute post-block. We blocked her, walked away, saw some other patients. And this is a short clip, but you can see that we're able to express fluid out of her abdomen. She got that completely opened up, a wick drain, and was discharged, comfortable. And I started her on PO antibiotics and pain medication, which was great because she got to leave and not have procedural sedation. Your case?
And yeah, in our case, we had basically complete resolution of pain at about a 30-minute assessment post-block, and then we discharged with anti-inflammatories.
Yeah, so another win, I think, for ultrasound-guided nerve blocks in the ED. Stay tuned. I actually think for the mesenteric adenitis case, another block that we commonly do in our department, the erector spinae block, would be even better. So we can talk about that in a following case.